Hi everyone, hope you're ready for another webinar from Plant-Based Health Professionals UK and are comfortable with something to eat or a glass of water for the next hour, where we're going to be joined by Dr. Meagan Gray. So just a quick introduction for those of you who don't know me. My name is Rahini Bajekor and I'm a nutritionist and communications lead at Plant-Based Health Professionals UK, which is an organization dedicated to promoting the health benefits of a whole food plant-based diet for the prevention, management, and treatment of common chronic diseases. So this evening's webinar has been a while in the pipeline. We wanted to cover this topic for many months since the webinar program first started over 2 years ago, as non-alcoholic fatty liver disease now affects a third of the world's population and is growing ever faster in the UK and all over the world. And before I introduce our next speaker, I just want to alert you to some of the other webinars that we've got coming up over the next month. So we're going to be joined by one of our long-standing members, Elena Holmes, to discuss plant-based diets and omega-3s. This one has been put in the diary by popular request, as I know lots of you have got questions about supplementations, the best foods for omega-3s and everything else. And Elena actually completed her dissertation in this subject, so definitely register for that. All the details are up on our website. We're also going to be joined by Dr. Tila Kansagra, who's going to discuss chronic fatigue and plant-based diets, and she will be touching on aspects such as long COVID as well. And this is going to be a really helpful webinar, particularly for anyone who's working with patients who have chronic fatigue syndrome or who have autoimmune conditions, or if you personally want to pick up some tips as well for minimizing fatigue as well. This is going to be a really great webinar. So I'd like to thank our sponsors, particularly veganfitness.com, who kindly lend us their Zoom platform, and the American College of Lifestyle Medicine and the British Society of Lifestyle Medicine for kindly providing us with CPD and CME accreditation. You will receive a certificate in your inbox in a few days' time. And lastly, a reminder to consider supporting our work, particularly if you enjoyed this webinar. The best way to do so is to join us as a member. This is open to everyone around the world, and our membership is rapidly growing. You can visit pbhp.uk to subscribe to our free weekly newsletters. And we've also recently just announced our conference, which is going to be on the 9th and 10th of September. So do go and check that out. The details are up on our website, and we're going to be releasing more information soon. Do consider donating as well to support this webinar program and the rest of our advocacy work via pbhp.uk/donate, and follow us on Facebook, Instagram, and Twitter for more updates. And last but not least, we're going to be joined by Dr. Meagan Gray after her presentation for a live Q&A. So at any point during her presentation, if you've got a question, please pop it in the Q&A box at the bottom of the screen, as that's the best way of making sure that your question gets answered. And don't forget to introduce yourself in the chat and mention where you're watching from today and what you do. It's a really great way to interact with everyone else who's watching. So now I'd like to welcome Dr. Meagan Gray, who's an assistant professor of medicine at the University of Alabama at Birmingham in the Division of Gastroenterology and Hepatology. I'm going to let her introduce herself, but we're going to be joined by Meagan after the Q&A, so I'll see you then. And best of luck, Meagan, and thank you so much for joining us this evening.
Well, thank you so much for that kind introduction. As she said, I'm very thankful to have the opportunity to present to you all today. This topic is kind of near and dear to my heart. I do follow a plant-based diet myself, and as I was going through my training for gastroenterology and hepatology, kind of landed in liver disease and non-alcoholic fatty liver disease, which was just such a nice marriage of my own personal interests in nutrition and also, a disease that's affecting a large percentage of our population. So this is one of my favorite topics. So I'm very excited to talk with you today about the benefits of a plant-based diet and non-alcoholic fatty liver disease. So the key questions that we'll be addressing today. So first, it's important to have a background of some baseline knowledge of prevalence of NAFLD and how it is affecting us worldwide and what the associated risk factors are for the disease. We'll just briefly go through the pathophysiology of NAFLD because that will help us understand how these different macronutrients.
Unfortunately, your slides aren't showing. I think you just they were fine before, but they've gone off. When we did the practice, they were showing up. Yeah.
I'm sorry about that. Is that better?
Yes, you can see them now. Thank
Okay,
you.
I'm so sorry about that. Second, we'll talk about the pathophysiology of NAFLD. Oh, okay, there we go. How do specific macronutrients affect NAFLD? And then lastly, what diets encompass these recommendations? So first, just starting with the prevalence, I think it's always important for us to just make sure we're all on the same page with definitions. So sometimes different terms in fatty liver disease can be kind of thrown around interchangeably when they're really not interchangeable. So NAFLD encompasses a spectrum of disorders. So most patients will have what's considered non-alcoholic fatty liver. So that's about 70 to 75%. And then the other 25 to 30% will have what we consider to be non-alcoholic steatohepatitis. So the distinction is important because those who have non-alcoholic fatty liver basically just have simple steatosis in the liver without much inflammation. And these patients are at very low risk to go on to get advanced liver disease or significant liver scarring, and extremely unlikely to develop liver cancer or progress to liver transplant. However, the patients who have NASH is specifically a liver biopsy diagnosis, although there's lots of interest in finding a non-invasive way to detect NASH. Right now, that is not available. And so the only way to diagnose a patient with NASH is with a liver biopsy. And on biopsy, we must see three things. So one, that we have fat in the liver; two, that there's inflammation; and three, that there's cellular ballooning, which is a sign of hepatocyte cell death. So these patients are the ones that, because of all that inflammation and hepatocyte cell death, will activate those fibrogenesis pathways and lay down lots of scar tissue in the liver. And they are the ones that are at risk for developing cirrhosis and all of the end-stage liver disease complications. So as we go through, especially some of the dietary studies that we'll go through, it's really important to really know that there are not many dietary studies that are looking at things like NASH. So a lot of the dietary studies are looking at hepatic fat and the reduction in hepatic fat, which is important. But as a hepatologist, things that are most important to me is, does my patient have NASH, and how much scarring and damage is in their liver from that fat and inflammation. And unfortunately, dietary studies haven't evolved yet to really look at that very closely, but we'll talk about that a little bit more. In terms of worldwide prevalence, it is correct that worldwide prevalence of NAFLD is about 25. And we know that in patients who have type 2 diabetes, it can be over 50%. But then when we look at NASH, as I mentioned before, that is not as common as NAFLD. And so worldwide prevalence of NASH is somewhere between 1 to 6%. But when we look specifically amongst patients with type 2 diabetes, we can see that that can be up to a third of those patients. And of course, as screening guidelines for NAFLD and NASH have come out over the last year, you'll notice that that type 2 diabetic population is one that is targeted for screening. So I think this is a really important slide, just looking at how the different risk factors impact the prevalence of both NAFLD and NASH. This was such a great study because they did have both MRIs, which can look at how much hepatic fat there is, but also had liver biopsies looking for NASH. So this was just really nice, kind of isolating the different metabolic risk factors and how each of those can predispose someone to NAFLD or NASH. So you can see kind of as you move left to right, starting with obesity on the left, you see about half of those patients have NAFLD and about a quarter have NASH. The diabetic population, you can see, is more affected with both diseases. And as you move over to the right, where we're starting to look at metabolic syndrome and this high-risk group that was defined by the authors as Hispanic females that were obese and had type 2 diabetes, you can see, up to 75 to 92% of patients with NAFLD and almost 50% of those had NASH. So again, as screening guidelines have come out, those are populations that really need to be targeted for advanced liver disease because they're at such high risk. So we do know that the prevalence of NAFLD and NASH does vary across racial and ethnic groups. Of course, I'm showing you data from the US, which I I realize maybe slightly different than what you see in your populations, but here in the United States, the highest prevalence of both NAFLD and NASH is in our Hispanic population and our non-Hispanic white population. Here, the lowest rates of NAFLD and NASH are in non-Hispanic Blacks and Asians. And I know that that is a little bit different where you guys are. But what's important is not only the prevalence of NAFLD and NASH, but the prevalence of fibrosis, because liver fibrosis is what puts you at highest risk to develop cirrhosis and end-stage liver disease complications. And what you can see from this picture here, although there's not exact percentages listed, but fibrosis is actually fairly similar across the different ethnicities, slightly lower in our Asian population, but otherwise fairly similar. And so that's really important when we're talking about screening also, to make sure that we're screening all ethnicities for fibrosis, because they are all at risk. So moving on to the pathophysiology of NAFLD, I'm not going to go into this into too much detail, but just to give you kind of a quick overview, because I think it will be helpful as we discuss some of the different macronutrients. But excess free fatty acids is really what leads to NAFLD. And there are three main sources of free fatty acids coming into the liver. And so 15% of free fatty acids are coming from what we're eating in our diet. The majority of free fatty acids are coming from the breakdown of adipose tissue, so about 60% coming from there. And then about 25% of free fatty acids are coming from de novo lipogenesis, meaning that the liver is making these free fatty acids. So as those free fatty acids come into the liver, they have a couple of different pathways that they can go down. So we want a lot of the free fatty acids to be oxidized. That's one healthy way to remove those free fatty acids from the liver. A second pathway is the formation of triglyceride synthesis. So some of those free fatty acids will remain in the liver as triglycerides, and then some will be exported as very low density lipoproteins. So when we look at the liver biopsy slide and we see kind of those white droplets inside the liver cell, that is literally triglycerides just sitting inside the liver cell. And so the more free fatty acids that are coming into the liver, that system can get overwhelmed. And so those excess free fatty acids will get shunted into triglyceride synthesis and liver steatosis. So those excess free fatty acids coming in is very important. And we'll kind of go through how those macronutrients can affect these different pathways and kind of shunt the liver towards more triglyceride synthesis. So next, the majority of the talk today will really be talking about how specific macronutrients affect NAFLD, and those can help inform dietary guidance. So first we'll start with fat. So as you know, there's different types of dietary fats. So we have our trans fats, which are things like hydrogenated vegetable oils, fast food, cakes, pastries, chocolate, fried foods, all the yummy things. Saturated fats, these are very common in animal products. This is the main source that we see saturated fats, also things like butter and full-fat dairy. But there are some plant-based sources of saturated fats as well, and that includes things such as coconut oil and palm oil. And then, of course, our unsaturated fats are predominantly coming from plants. So these are things like olive oil, nuts, avocados, but also can include cold water fish. So there's several mechanisms in which both saturated and unsaturated fats can influence NAFLD. So I apologize if this diagram looks like a lot going on, but we'll kind of go through it one by one. But first, kind of focusing on saturated fats, and so focusing on the left side of this diagram. So one of the things that has been shown is that saturated fats actually increase lipolysis. And so that's the breakdown of adipose tissue. And so as we were looking at on the previous slide, as that adipose tissue breaks down, it releases lots of free fatty acids into the circulation, which then does lead to excess free fatty acids coming into the liver. So when the system is overwhelmed, as we discussed, it may be difficult for the liver to oxidize and excrete all of that as very low density lipoproteins. And so that can lead to excess formation of triglycerides within the liver. Other things we know that saturated fatty acids can do is promote de novo lipogenesis. So not only are they bringing excess free fatty acids into the liver by the breakdown of adipose tissue, but also they're promoting the formation of free fatty acids within the liver itself. So kind of almost a two-hit phenomenon to bring excess free fatty acids into the system. And then if you kind of move down the diagram here, you'll see that other things that saturated fatty acids can impact is that once those excess free fatty acids are in the liver, saturated fat can also inhibit the excretion of very low density lipoprotein and can also inhibit beta oxidation. So not only are we bringing excess free fatty acids in, but also we're inhibiting the liver from being able to process those in a healthy way. So really up titrating the triglyceride synthesis, which of course leads to liver steatosis. On the rightmost side of the graph as well, you'll see that saturated fat has also been shown to cause hepatocyte apoptosis. So that's hepatocyte cell death, and that's due to oxidative stress as well as inflammatory cells. And so as we were looking at on that initial slide with the differences between NAFLD and NASH, that hepatocyte apoptosis is what leads to NASH and steatohepatitis. So saturated fatty acids are really impacting almost every step along the way between NAFLD and NASH and triglyceride synthesis. So moving on to talk about unsaturated fats. So they thankfully do a lot of the opposite things, and so can be very healthy for patients with NAFLD. So one of the things unsaturated fatty acids can do is inhibit lipolysis. So inhibit those excess free fatty acids coming in from the breakdown of adipose tissue. Other things, unsaturated fatty acids can inhibit steroid-regulatory element binding protein, which you see at the middle of this picture here. That binding protein is important in activating de novo lipogenesis. So by inhibiting that, we're inhibiting the liver from producing its own free fatty acids. Unsaturated fats can also be anti-inflammatory, reduce some of that oxidative stress associated with hepatocyte apoptosis. And lastly, unsaturated fatty acids can promote beta oxidation. So even if there are excess free fatty acids coming in, can help the liver to process those and oxidize those in a healthy way. So there's lots of different mechanisms in which these fats impact NAFLD. And so as we kind of start to go through some of those dietary studies, this kind of gives us that framework for understanding why we're seeing some of the results that we're seeing. So this is the first study we'll look at. This is actually just looking at insulin sensitivity, which I think just briefly to look at before we move on to the liver studies. But this was looking at healthy men and women and feeding them a diet that's high in saturated fat. So this was 162 healthy subjects. They were fed an isoenergetic diet, so no change in their baseline caloric intake, but either the diet was high in saturated fats, almost a third of calories coming from saturated fats, or about a third of calories coming from monounsaturated fats. And they followed this diet for 3 months. Because it was isoenergetic, there was no changes in the weights of the participants. But as we know, the quality of diet can be extremely important. And so even just this one change for a fairly short amount of time led to significant changes in insulin sensitivity index. And so you can see saturated fat significantly reduced insulin sensitivity while there really wasn't much change in those patients eating the high monounsaturated fatty acid diet. So moving on to our more liver specific studies. So you'll notice that a lot of the things that are measured in liver studies, in dietary intervention studies as well, is the quantification of liver fat. So most often that's done with MRI, so MR spectroscopy or MR proton density fat fraction are two ways that liver fat can be measured. And those are some of the most common things that we'll see. Sometimes we also see kind of surrogate markers of NAFLD, which might be things like elevated liver test, but MRI is probably the best way for us to really look at liver fat reduction. So this was a study looking at patients receiving 1,000 extra calories of saturated fat versus unsaturated fat versus carbohydrates, and how that impacted liver fat over a time period of 3 weeks. So given that the increase in caloric intake was similar, the weight changes amongst the groups were similar, but you can see that the patients who were fed the saturated extra calories had significant more increase in liver fat compared to those in the unsaturated and carbohydrate groups. So there you can see in the saturated fatty group, especially, it started at kind of baseline about 5% liver fat, which would be considered healthy, but just even after a few weeks was all the way up to 7.5% liver fat. So that's a pretty dramatic increase in such a short period of time. And you can see that was much more increase than what was seen in either of the other two groups. So this also was looking at saturated versus unsaturated fats, and this was an overeating study. So this was 39 healthy subjects who were fed about 750 extra calories a day with muffins. And so those muffins were either made with saturated fat from palm oil or polyunsaturated fat from sunflower oil. Again, this was a fairly short study for 7 weeks, but was somewhat unique in the fact that it was able to be blinded since all patients were eating muffins. And the weight gain was similar between the two groups. So when we look first of all at liver fat, you can see that the patients who ate the muffins that were high in saturated fat had significant increase in liver fat compared to really not much change at all in the polyunsaturated fatty acid muffin group. Next, looking at visceral adipose tissue, you can see that the patients eating the muffins high in saturated fat had more increase in visceral adipose tissue compared to the other group. I'm so sorry. And then lastly, looking at lean tissue, this was, I think, a really interesting study because it helped us see kind of how that weight gain was distributed differently between the groups. And so those who were eating the muffins high in polyunsaturated fatty acids actually had more increase in lean tissue, whereas it seemed like the saturated fat group tended to shunt that weight more towards visceral adipose tissue, which we know is unhealthy. So just a neat study kind of comparing the two different types of fatty acids. So this was another dietary study looking at an isocaloric diet, either high in saturated fat coming from butter or unsaturated fatty acids. This was a 10-week study. And since this was an isocaloric study, there was no weight changes in either of the groups. So they measured not only liver fat, but also other metabolic factors like triglycerides, cholesterol, and LDL. And so you can see consistently across the board that the patients who were eating the diet high in polyunsaturated fatty acids had consistent reduction in liver fat, triglycerides, total cholesterol, LDL, where we see the opposite effect in those that were eating the diet high in saturated fat. And so based on some of the diagrams that we were looking at earlier, these are really in line with what we would expect. And then this is looking at a monounsaturated fatty acid diet versus a diet high in fiber versus a control group in pre-diabetic patients over 12 weeks. And so this is, I think, always interesting to look at. Of course, we always do recommend high fiber diets, but really hadn't had a lot of studies on what the high fiber diet does for the liver. And so this was really interesting just to see that the patients who ate diets high in monounsaturated fatty acids did have significant reduction in their liver fat fraction compared to really no changes at all in the fiber or control groups. So just really promoting how much those unsaturated fatty acids can be healthy for patients with fatty liver and promoting beta oxidation and just healthy processing of those excess free fatty acids. So now we'll kind of move on to protein. So I don't need to tell this group, but there's lots of different ways to get protein on a plant-based diet. These are just some of those listed here. And then of course, we all know there's lots of different ways to get protein on a non-plant-based diet. So this was a study, unfortunately, studies with protein, I feel like are much more limited. And so some of the things I'll be including for you to look at are association studies and kind of large population samples. Certainly there's lots of limitations to these types of studies, but just kind of showing you what we have. I'll show you one randomized study, but the data is pretty limited in this macronutrient. So this was looking at a large population study out of Israel and just looking at prevalence of NAFLD and then dietary intake, including things like carbohydrates from soft drinks and calorie intake from meat protein. And so what we see here is that compared to patients who did not have NAFLD, there was significantly more intake in carbohydrate from soft drinks and significantly more meat protein intake in the patients that did have NAFLD. So twice the amount of carbohydrates from soft drinks and 27% more meat protein. So animal protein is also associated with high odds ratio for NAFLD in a large population-based study out of the Netherlands. So here we're looking at quartiles of protein intake. And so the blue is total protein, red animal protein, and green vegetable protein here. And then, of course, we're looking at odds ratio in the bar graph. So what you can see is as we kind of move from left to right across those quartiles of protein intake in the green, the vegetable protein, really the odds ratio for NAFLD isn't really changing at all across those quartiles. But what we can clearly see is that the animal protein, as we move into higher quartiles of intake, we see that stronger association for NAFLD. So in the fourth quartile, we see that the animal protein intake is associated with almost an odds ratio of 2 for prevalence of NAFLD. So similarly, this was looking out of a large population-based study in Israel, and this was looking at quartiles of meat protein intake. This was the same group that looked at the earlier study looking at carbohydrate from soft drink intake as well. And so clearly there's a stepwise increase. As we increase meat protein intake, we're increasing our percentage of patients with NAFLD. What was interesting for this was they found that the consumption of just 36 grams of red meat per day resulted in an odds ratio of 3.6 for NAFLD. So that's really just one serving of red meat. So I don't know the patterns of meat intake in your population, but here in Alabama, there tends to be lots of red meat intake. So it would not be uncommon to see, bacon and sausage for breakfast, hamburger, steak for lunch and dinner. So a lot of red meat intake in the United States and definitely in Alabama. So for someone to have 4 to 5 servings of red meat per day here would not be uncommon. And so just seeing how dramatic the results are, even just for one serving a day, you really worry about those patients who are eating more than that. And so this was looking at high red and processed meat intake in NAFLD and insulin resistance, also out of the similar population of Israel. And so you can see similarly that stepwise increase in prevalence of NAFLD as well as prevalence of insulin resistance. And this study, is even looking at smaller amounts of red and processed meat consumption. So that highest group on the right was just more than half of a portion per day. And even that having significant association with the prevalence of NAFLD and insulin resistance. So also what has been shown is that the increased risk of death and all-cause mortality due to chronic liver disease is strongly associated with red meat and processed meat. So here we're looking at hazard ratios for death from chronic liver disease across total red meat, processed meats, unprocessed, heme iron, nitrates, and nitrites. And so you can see, especially the total red meat intake, processed food, processed meat intake, et cetera, has significantly higher hazard ratio for death from chronic liver disease, which is really important. So we think, there's lots of hypotheses for why this may be the case, but we think that trimethylamine N oxide may play a role in that association that we see between red meat intake and many chronic liver diseases. So we know that people who eat diets that are high in animal protein intake quite a bit of carnitine and choline through those proteins. And our gut flora metabolizes carnitine and choline to trimethylamine. And then in the liver, trimethylamine is converted to trimethylamine N oxide. And that has been linked to all kinds of different things, such as heart attacks, strokes, type 2 diabetes, et cetera. And so it has been shown, this is really the only study looking at looking at TMAO and NAFLD, but this was looking at levels of TMAO in the blood, and then the NAFLD activity score. A NAFLD activity score is a measure of NASH on biopsy. So NAFLD activity scores 5 or higher are diagnostic of NASH. So this is looking not only at the steatosis on the liver biopsy, but also the inflammation and the hepatocyte apoptosis. So looking at all of those factors. So it's unique to have a biopsy study. But as you can see, that as you increase serum levels of TMAO and choline, you see an increase in that NAFLD activity score. There are certainly limitations to this type of study. We know that biopsy review by pathologists can have significant heterogeneity, but it is just interesting to see the trend. So it's hypothesized that TMAO may lead to NAFLD and NASH due to decreased synthesis of bile acids. It may limit enterohepatic circulation of bile acids and also may modulate glucose and lipid metabolism. So there's lots of different hypotheses in terms of the link between animal protein and NAFLD. So we've just summarized some of the associations that are known here. So starting on the left of this diagram, animal protein brings in a lot of branched chain amino acids. We know that branched chain amino acids can activate the mammalian target of rapamycin complex. That plus insulin can lead to insulin resistance, but also that mTOR complex can activate steroid-regulatory element binding protein, which was one of the proteins that we reviewed previously that activates de novo hepatic lipogenesis. So that may be one pathway by which animal protein can lead to excess free fatty acids in the liver. The pathway on the right here is kind of what we were just talking about with TMAO. And then you see kind of this blue bubble in the middle, that includes other things that we think are likely along that pathway as well, but maybe not quite as well defined. Interestingly, patients that follow a plant-based diet, which is typically low in methionine, tend to have more FGF21 activation, which can be very anti-inflammatory in the liver. One of the things that FGF21 does is inhibit steroid-regulatory element binding protein 1. It also can activate free fatty acid oxidation in the liver. And so patients that follow these types of diets tend to have more FGF21, which of course can be very healthy for the liver. So maybe one of the ways in which a plant-based diet can help prevent NAFLD. So this is really the only good study looking at animal versus plant protein and liver fat, liver inflammation, type 2 diabetes. So these were patients that followed either a diet high in animal protein or high in plant protein for a very short period of time, just at 6 weeks. And here we're looking specifically at intrahepatic lipid content. So you can see actually that both diets did significantly reduce intrahepatic lipids. And along with these diets, it is important to note that patients did lose weight in both groups. And of course, we know that weight loss can reduce hepatic fat. So both diets did reduce hepatic fat. They reduced markers of insulin resistance and also reduced markers of hepatic necroinflammation. So I think it's important to know that these studies are out there because patients sometimes will ask us about these. And so I think a very common question that we get in our liver practice is about the keto diet that's very popular here in Alabama. I think partly because people down here really enjoy meat intake. And so anytime they find out that there's a diet that lets them eat lots of meat, they tend to be more likely to follow that. And so these are always things that we have to talk to them about. What's difficult in studies like this is that the type of animal protein was not discussed. So we don't know if these were red and processed meats. We don't know if this was lean meat. We really just don't have much data to help us understand, the potential benefits or why kind of both groups performed similarly. What I do always kind of tell patients, which I'm sure you're very well aware with, is of course that processed meats are classified as carcinogenic, as the World Health Organization tells us, and that red meats are likely carcinogenic. And so anytime we recommend, patients are following diets that are extremely high in red and processed meats, we have to talk to them about the risk associated with following those types of diets. So if you can get similar results by eating plant-based proteins, then that seems like a much safer way to proceed. So moving on, lastly, to carbohydrates. Of course, we know that there are complex carbohydrates and refined carbohydrates, which are very different. Some of the things that are very challenging in evaluating the literature regarding carbohydrates in NAFLD is that carbohydrates are often just lumped together as one big group. And so you'll see studies where patients are following low carbohydrate diets or high carbohydrate diets, but really the study provides minimal information about what kinds of carbohydrates they're limiting or adding. And so it makes it difficult because, as we all know, there's a huge difference between eating a diet high in complex carbohydrates versus eating a diet high in refined carbohydrates. And so when those things are not defined within the studies, it makes it confusing for patients and also just more challenging to interpret. So we do know that sugar intake can increase hepatic de novo lipogenesis. One of the ways it can do this is through carbohydrate receptor element binding protein, which is one of the proteins that activates lipogenesis within the liver. So this mechanism can be activated both by fructose and glucose. I know there may be some questions later about fructose and lipogenesis. And I'll show you sort of what we have available in terms of those studies, but both fructose and glucose can promote lipogenesis in the liver. So this was one of the overfeeding studies that looked at having sugary beverages, high intake of sugary beverages for 3 weeks. And so sugary beverages, of course, fall into that refined carbohydrate category. So this is looking at baseline average of about 9% liver fat. And just in that very short time period of 3 weeks, seeing that liver fat percentage increase to almost 12%. So very dramatic rise in liver fat with simple carbohydrate overfeeding. What was interesting as well to note in this study was that the body weight didn't really change much at all. So they only saw a 2% increase in body weight while there was a 27% increase in liver fat. I'm sorry about that. And this was just looking at ALT levels. ALT levels are not really the best way to monitor NAFLD, but it is notable that the ALT levels did increase in patients who had those high intakes of sugar. Of course, this wasn't a controlled study, but just an interesting observation in patients eating high sugar. So this study was looking at 60 overweight or obese participants given an extra 1 liter of beverage per day for 6 months. So they either received 1 liter of regular soda, skim milk, diet soda, or water. And what you can see over that time period is that there were really no changes at all in the skim milk, diet soda, or water groups, but there was significant increase in liver fat in the group that was drinking the 1 liter of regular soda. So I'm very fortunate to have a dietitian in my practice that sees my patients as well. And the number one thing we always recommend for our patients is reducing intake or eliminating intake of sugary beverages if that's something that's currently in their diet. This was a really nice study looking at the reduction of refined carbohydrates in adolescent boys. So they followed either a usual diet for 8 weeks or a very low free sugar diet for 8 weeks. And what you can see is that in those following the usual diet, there was no difference at all in their hepatic fat fraction from baseline to 8 weeks, while there was significant reduction in liver fat in those following the low free sugar diet. Of course, this was a very small study, but does show that just as quickly as the liver can accumulate fat on a high refined carbohydrate diet, the liver can also get rid of that fat very quickly when we cut out those refined carbohydrates. And this is really the best study out there that is looking at fructose. And so I apologize if it doesn't answer all of your questions. There's significant heterogeneity in fructose studies. So in this top part here, I was kind of looking at substitution trials, and that's kind of where you see fruits coming in. I would assume that most of the questions about fructose are in relationship to fruit. But there was such heterogeneity among those studies that it's really difficult to make any firm conclusions. Where we can make some conclusions is in the middle here with the addition trials. This is the addition of sugar sweetened beverages. And so clearly there is increase in intrahepatic lipid content with the addition of sugary beverages. But in the other studies, even the subtraction studies, the data is very heterogeneous. and difficult to make firm conclusions. So all I can really tell you about fructose firmly is that we know that sugar sweetened beverages increase hepatic fat, but otherwise it's a little bit challenging to make strong conclusions. So lastly, what diets encompass these recommendations? So weight loss remains the backbone of therapy for fatty liver at this time. So at the bottom here, we're looking at just simple hepatic fat, and even weight loss of 3% body weight can be beneficial for steatosis alone. As we move into patients that have more inflammation and ballooning and NASH and even liver fibrosis, it really does take more weight loss to start to see benefits in those categories. So typically we'll recommend to patients that goal weight loss should be about 10% of body weight, which we know also has significant benefits for type 2 diabetes, blood pressure, cholesterol, et cetera. So some patients who lose 10% or more of their body weight may be able to even reverse some of the scarring and damage in the liver, although not always, but definitely can see significant improvements in NASH and steatosis. So this, I think, is important to note. I know that we were talking before the webinar started just about that you all do see a large South Asian population that tends to have lean NAFLD. And so this study may be the most relevant for that population. But we do see that weight loss helps NAFLD regardless of body weight. And so this is looking at patients with both lean and overweight NAFLD. And so lean NAFLD is here in the purple. And you can see that even patients who are lean at baseline, who are able to achieve 5 to 10% body weight loss, may have complete resolution of their NAFLD, similar to patients, or maybe even better response than patients who are overweight. So here in the 10% bar, you can see that the lean patients, 100% of them reverse their NAFLD with 10% body weight loss. So it is still important, even if your patient is lean, that weight loss is still recommended. I'll say here in the United States, this may be completely different from what you see, but we do see patients coming to the fatty liver clinic with severe fat and normal body weight. And very often those patients will actually have alcohol-induced fatty liver. So that's always something just to keep in the back of your mind as well. If the clinical picture, the patient is lean and doesn't have any other metabolic comorbidities, always think about things like alcohol leading to disease as well. So dietary studies for NAFLD are not as robust as we would like as hepatologists. So this was looking at the DASH diet, but the outcomes here were really looking at liver tests, which aren't as robust as a measure as something like MRI or a biopsy. But these were patients who followed a DASH diet. DASH is the dietary approach to stop hypertension diet, which is low glycemic index, also rich in fruits and vegetables, whole grains, does include some low-fat dairy products. But overall kind of follows those guidelines of low saturated fat, low refined carbohydrates that we would recommend. So you can see that over a period of 8 weeks compared to a control group, patients who followed the DASH diet did see significant improvement in liver test, as well as insulin levels and insulin resistance measures by HOMA-IR. And then we'll move on to some of the other dietary studies that did use MRI to evaluate hepatic fat. So this is looking at 3 different groups, either one following a low-calorie diet, a second group following a low-calorie, low-carbohydrate diet, and a third group following a low-calorie, low-carbohydrate plus soy protein diet over 8 weeks. And you can see here that all groups did reduce body weight, and all groups did have improvement in AST and ALT levels, but you can see the most improvement in those who followed the low-calorie, low-carbohydrate plus soy-containing diet. And it's thought that soy may be able to help fatty liver by inhibiting that serol regulatory element binding protein that was one of the important factors in de novo hepatic lipogenesis, and also activating PPAR alpha, which may aid in beta oxidation in the liver, can also reduce lipid deposition and increase antioxidant capacity. This was also a commonly quoted study in our literature, but this is an ad libitum study looking at a Mediterranean diet versus a low-fat diet over a period of 12 weeks. So the nice thing about this was, of course, patients were able to eat as much as they wanted. So this was not specifically focused on weight loss. But as you can see, patients did have some weight loss in both groups, but there were significant reductions in cholesterol and triglycerides in the Mediterranean group, which was different than the low-fat group. Both groups did reduce their hepatic fat as well as their ALT levels. So those were statistically similar between the two groups, but there was dramatic difference in the reduction in cholesterol and triglycerides in patients that followed the Mediterranean diet. So this was a more recent study. It's a little bit more complicated to explain as well, but larger, and certainly one of the largest dietary studies we have in fatty liver. So 294 subjects total. So one group was randomized to healthy dietary guidelines, which included standard nutritional counseling plus physical activity. The middle group was the Mediterranean diet group, who also included 28 grams per day of walnuts, which provides 440 milligrams per day of polyphenols plus physical activity. And then there was a green med diet group, which included the Mediterranean diet in addition to green tea and a Mankai shake, which gave patients a total of 1,240 milligrams of polyphenols per day. Polyphenols are felt to be anti-inflammatory and promote antioxidant activity in the liver. And so just looking at how those polyphenols may have additional impact on fatty liver in addition to the Mediterranean diet. And so they were looking specifically at MRI results. So on the left, first, we're looking at weight changes. So you can see that as most weight loss studies we see, there was maximum weight loss at 6 months, followed by a gradual increase up to that 18-month mark. But the most significant reduction in weight was in the patients following the green med diet, and that did last at that 18-month mark as well. And then on the right, we're looking at liver fat change, and you can see that all patients did lose liver fat, but the most significant reduction of 37.7% reduction of liver fat was seen in those following the green med diet. And this was just representative MRI images from this study, which I think are always just really neat to look at. So at baseline, you can see patients had significant liver fat, so 14% on the left and almost 20% on the right. And then after 18 months and about 12% body weight loss, you see that both groups had significant reduction in liver fat. The Mediterranean group with the walnuts reduced their liver fat from 14 to 8%. And in the green med diet group, you see a really dramatic reduction of almost 20% fat down to 0.75%. So hopefully more to come with polyphenols, but very exciting initial results. The diets that encompass these recommendations overall and are best for NAFLD do include the Mediterranean and plant-based diets. I like this Harvard plate because I think it touches on all of the factors that we like to discuss with patients. So certainly lots of fruits and vegetables, but really focusing on unsaturated fats in the diet. So olive oil, canola oil, etc. Drinking lots of water, avoiding those sugary beverages. And then I like that it includes healthy proteins like beans and nuts. I think a lot of dietary resources don't always include vegetarian sources of protein, but I like specifically that it also talks about cutting out red meat and other processed meats. So our key dietary recommendations for this population are to reduce refined carbohydrates, replace saturated fats with unsaturated fats, reduce trans fats, and then of course eat more plants. So this is one of my favorite quotes, but let food be thy medicine and medicine be thy food. So that's the end of the talk for today, but I'm certainly happy to take additional questions and see if I can answer any of those for you.
Thank you so much, Meagan. That was fascinating and incredibly comprehensive. I actually didn't know enough about the topic, so I really, really enjoyed it. And we have had a few questions, a couple of people who couldn't be here as well, who wrote in their questions. So if you don't mind, could I just fire away? Would you be able to answer whether there's an upper limit for the amount of whole fruit one should consider eating in a single sitting? So obviously we know that fruit juices and things are not advisable, but we're talking about whole fruit. You know, there are obviously studies showing people eating 20 fruits a day and things. What are your thoughts on an upper limit, either in a sitting or in the course of a day?
Yeah, that's an important topic. I was actually reviewing a paper just a couple of days ago that was looking at high fruit intake and fatty liver, and I can certainly find that paper and send to you. Sorry about that. But it was surprising to me, and I haven't dug into the quality of the data, but did suggest that higher quantities of fruit intake daily may potentially be associated with NAFLD as well. So I think certainly focusing on fruits that have lots of fiber content, that may have a lower glycemic index, would be important for someone who has NAFLD. Of course, if you don't have NAFLD, then I don't know of any data that would show any harmful effects of lots of fruit intake.
Yeah, that would be great if you could share that paper. I think, they've seen even in people who've got diabetes that it doesn't seem to be an upper limit when it comes to whole fruit consumption. So it'd be interesting what you're saying is quite interesting, maybe kind of sticking to more berries and yeah, those sort of like high fiber foods, citrus fruits and things like that. Is that what you would probably suggest for someone who already has
Right, exactly. I'd be happy to share that paper.
and dried fruit is something that you'd want to limit as well?
Yeah, dried fruit, of course, would kind of fall into that high glycemic index. So yeah, I would limit those.
Wonderful. So obviously, what are you, you touched on the importance of healthy fats, and I was wondering if you had any thoughts on sort of Neil Barnard's more low-fat, whole food plant-based approach that's obviously free of oils compared to the more Mediterranean diet, which is higher in fat and does seem to be beneficial for maybe triglycerides, but Barnard's diet might not be. I just wondered if you had any thoughts on that, and are there pros and cons of both?
Yeah, I think it definitely, there's lots of different thoughts out there about fats, and I know it can be a very controversial topic. I think again and again in liver disease or in non-alcoholic fatty liver disease, we do consistently see that unsaturated fats are very beneficial. And so I think certainly sticking within sort of recommended guidelines for fat intake and not going outside of those, but when you are eating fats in your diet, making sure that those are unsaturated is beneficial for sure. Because of how helpful we've seen those unsaturated fats be for the liver, I think it would be difficult to recommend a diet that excludes those. But I know for patients wanting to lose weight, often they really do want to reduce their fat intake, but we haven't really seen a benefit of reducing those unsaturated fats for the liver. And I know some patients have really increased the amount of unsaturated fats that they eat and have seen really great benefits from that. So really no reason to limit from our standpoint outside of just guidelines, general fat intake guidelines.
Great, that sounds really sensible. And there was a question from a GP who couldn't attend. She couldn't make it tonight, but she's going to watch it on catch up. And her question was, when dealing with isolated marginally raised ALT levels that appear on a blood test, many sort of GP threads and discussion groups argue that we should immediately jump on that first result and investigate, as some have found cancers and things like that. She was wondering whether you think this is a sensible approach to sort of say to a patient, it's likely fatty liver, suggest making some dietary and lifestyle changes, and then repeat the test and only investigate if it remains sort of slightly elevated again. Do you have any thoughts on the best way of dealing with something like this? Because you do see in blood tests, these slightly raised levels.
Yeah, I think I love that question was raised, because I think that's extremely important. I think also, I don't know how your laboratory ranges are in the UK, but here in the US, often the laboratory values for normal liver test will say that AST and ALT levels can go up to 50 or 60 and still be within the normal range that wouldn't alert a provider of any abnormality. However, our Liver Society very specifically says that ALT levels should be less than 19 in women and less than 30 in men, and anything above that is elevated. And so we feel like we're missing lots of patients that have liver disease that could be caught early because we're ignoring these sort of minimal elevations that we see. So I think, of course, you have to take every patient one by one. I think if a patient has another reason to have had, a one-time abnormal liver test, maybe they were on an antibiotic or they had a viral illness or something like that, and you repeat it and it's normal, then that may not warrant further workup. But certainly someone that has two liver panels that are elevated deserves not only just, an assumption that they have NAFLD, but deserves that full serologic workup that we look for alpha-1 antitrypsin, hemochromatosis, autoimmune hepatitis, other autoimmune liver diseases, hepatitis B and C, et cetera. So anybody that has persistently elevated liver tests deserves that full workup. And I'm not sure if you guys have screening guidelines yet in the UK, but for the United States, there are now endocrine screening guidelines and screening guidelines from our liver society that is recommending screening for advanced fibrosis in patients who are at high risk of NAFLD. So that's screening patients that are obese, have type 2 diabetes, high cholesterol, high blood pressure, family history of cirrhosis, or elevated liver tests on routine blood work. So all of those patients should be getting some type of fibrosis assessment.
That's really helpful. Thank you. I'll definitely pass that on. So, Shireen has actually messaged to say that those normal ALT levels that you mentioned are actually very low compared to what we have in the UK. So that is really interesting and helpful for us to note. There's a question or a comment from Hans saying, great presentation, very comprehensive, and we've had loads of lovely comments in the chat box as well. And you mentioned in the beginning that fat from hepatocytes contributed to mechanisms causing NAFLD. Would you have any information if that means that fat from hepatocytes liberated during fasting or a fasting mimicking diet, so probably like the Volta Longo style, FMD, maybe a risk factor for non-alcoholic fatty liver disease?
Yeah, so there's all kinds of reasons that patients can have fat in the liver that we try to rule out before we give someone the diagnosis of non-alcoholic fatty liver disease. So some of those things can be, HIV causes fatty liver, Hep C causes fatty liver, alcohol causes fatty liver. We know that starvation causes fatty liver, TPN causes fatty liver. So all those different things can cause fat in the liver. We don't call those NAFLD, but those are other etiologies that can cause fatty liver, but the mechanism is a little bit different.
Thank you, that's super helpful. I just launched a little poll to get everyone's feedback. And there was someone who's mentioned, is the name for non-alcoholic fatty liver disease going to be replaced by metabolic associated fatty liver disease? So MAFLD rather than NAFLD.
Yeah, so the name is controversial for sure. I think lots of people think that the name is stigmatizing, and so there's a lot of interest in changing it. It sounds like most likely it will be changed to steatotic liver disease and not metabolic associated, because we know there are some patients who have disease without those metabolic risk factors. So most likely it will likely be changed to steatotic liver disease.
Interesting. Yeah, it's so hard to change condition or disease names.
I know it's really difficult because we're just now kind of gaining ground and getting widespread acceptance that it's a real disease and people are starting to look for it. And so there's, just a lot of talk about, is it even a good idea to change it at all? Or are we just going to go backwards in terms of the awareness?
Yeah, so tough, complicated choices. And what do you have any thoughts on some of the alternative sweeteners that have sort of become increasingly popular? There's obviously huge variation between, like the nutritive and non-nutritive sweeteners, but things like xylitol, birch sap sweetener, monk fruit, erythritol was recently in the news. Are there some that you just should definitely stay away from, or what are your thoughts on those for either prevention of this or people already living with non-alcoholic fatty liver disease?
Yeah, there's no data to guide anything that I say about this, but in general, we just recommend that patients, especially for beverages, drink 0-calorie beverages. And so if that includes artificial sweeteners, that's fine. But we just recommend staying away from the beverages that are high in sugar. Sure,
but also being aware perhaps that some of those could modify your palate and may lead you to seek out sweeter foods, although I think all of those things are kind of complex, aren't they? It's hard to tease them out totally.
There's data that can help you to argue either way, so
yeah, for sure. But I think that's what hopefully that answers the person's question. I think that covers almost everything that sort of came up, and we're actually able to finish up on time. So thank you so much. You had packed in so much information. This is such a pressing issue. I know that lots of people are going to be watching this on catch up, and I'll definitely share this widely with our audience. And with more GPs, nutritionists, dietitians and things who are working with patients, as well as people who are personally touched by this, which, considering this affects a third of the world's population, clearly all of us are, and it's just growing in prevalence. But thank you so much for coming on, and yeah, lovely comments, saying fascinating, really informative, loved it. Yeah, learned so much, wonderful webinar. So yeah, thank you
Oh,
very
great.
much.
Thanks so much. I appreciate the invitation again.
Have a lovely rest of your day, and thank you everyone, and good night.
Thank you.